My talk will be on LSD microdosing, and I will tell you something about the studies we have done. But first of all, I want to take you to my place. So I work in Maastricht, and that's in the south of the Netherlands, there. And we have a long-standing history on doing research with psychedelics. We did our first study with MDMA in humans in 1999. And I think around the same time we also did some studies with cannabis, and we never stopped doing those studies. I joined the team in 2003. And if you want to know more about the research we do, you can visit, it's not that visible, but it's stated psychopharmacology in Maastricht, psychopharmacologymaastricht.com. So, but what are psychedelics? You will all know what psychedelics are, but still I'm going to give you the definition that I use in my talk. So we have 4 classes of psychedelics. And we have the classical psychedelics, where psilocybin and LSD are the prototypical examples. They work mainly on the 5-HT2A receptor as an agonist. We have the empathogens with MDMA as a prototypical example. We have the dissociatives with ketamine, that is now also FDA approved, or as ketamine, to be used in treating treatment-resistant depression. And we have the unique substances, the dumping class, where cannabis and other substances are in. So what do we do in Maastricht? We mainly do lab studies in healthy volunteers and using the gold standard placebo-controlled experimental studies. We also do survey studies. So what we have done in the last years is we have done studies with psilocybin, LSD, ayahuasca and mescaline, and the 2 last ones we did not do as placebo-controlled studies. We also have another model, is that we do naturalistic studies. What does that mean? All over the Netherlands, but also Europe, we have retreats offering these psychedelics to healthy volunteers. We focus on the retreats where they include healthy volunteers, and there we then do a baseline measurement. So we test personality, well-being, creativity, empathy before they take the substance, and then afterwards. And we test that repeatedly to see whether there are persistent effects. I very much like these studies because the placebo-controlled studies, like I said, are the gold standard, but they are so expensive. So we have the opportunity to do pre-tests in these retreats, and then we can do more targeted research afterwards. So what is ongoing now is, or what we have planned is another microdosing LSD study. So we first did a dose-finding study, and we're now going to do a repeated dosing study. So we just, this week, received approval from the ethics committee, so I'm very happy about that. So what we're doing more is MDMA studies. We have currently a project that is running that is looking into the effects of MDMA on false memories. Why is this relevant? Because people might be present during a criminal act and they might be under the influence, and they might be interviewed by the police then. And we are looking into whether MDMA can influence false memories, the appearance of. What we're also doing, and I'm moving towards the LSD study now, is we also do studies with cannabis, a lot of studies. This is not my expertise, but I have a colleague who runs all these trials. We're looking into THC CBD ratios. We do driving studies to see whether it affects driving performance. We have real cars and we go on the road when people are drugged. We also no, but it's funny, but it's also highly relevant, because when patients receive that as medication, we need to know how it influences their driving performance. We're also doing the same study with the false memories with cannabis. And we also are doing studies with novel psychoactive substances. We just finished a study with JWH018, these stupid names. But anyway, my talk will focus today on LSD. And usually when people take it in a full hallucinogenic dose, they take between 100 and 200 micrograms. And for our study, we based ourselves on these numbers. So we used, like the definition states, 1/10 of a dose. But I will show you later on how much we used. So, to give you a bit of background, LSD was synthesized in 1938 by Hofmann, a Swiss chemist. And in 1943, he took it, he knew that he took it. And this is what he described. And why I show you this is because you might know this, a blotter with LSD on it, but also with the depiction of Albert Hofmann while he was tripping in the Swiss Alps and cycling. So every year we celebrate on the 19th of April this day when Albert cycled on drugs. First driving study. Yeah. So, but then something terrible happens. No, first something good happens because researchers did studies with LSD in patients. But then something terrible happens because politicians thought, well, this might become an epidemic, people taking these substances, drugs, and people might die. So what they did is they scheduled these drugs. And here you see, here you see the substance. It was synthesized back then by Sandoz, a chemical company, and it was called illicit. But what Sandoz did is they also put money in these trials, and when it was scheduled, they did not produce it anymore. They did not give money to do these trials. So, but the question here is, so it was scheduled out of fear. But the question is, was this fear justified? Here you see, I based it on prevalence data in Europe, but not a lot of people take psychedelics. In the Netherlands, it's slightly higher, it's 1.6%. So the conclusion is, it did not become an epidemic. What is scheduling? Here, the scheduling in the States is shown. What it basically is that if a substance like LSD is scheduled as Schedule 1, it means that it has no medical use and it has a high abuse potential. We know that it has medical use. We knew it back then, and now we're trying with improved methodology to show it again. We also know that it has a low abuse potential. So, to give you a short overview on the effects of LSD in a regular dose, we know that, and it's important to understand what we did and what we found. So, it has acute cognitive and emotional effects. It increases positive mood. It also decreases emotion recognition. So, recognizing the emotion people show, but it increases emotional empathy, and that is feeling for another and being aroused by the emotion you see. It decreases executive functions, so higher cognitive functions, and does it have adverse effects? Not really. What we know now, it's well tolerated in a clinical setting, and we also know a bit about the persisting effects, is that it induces a meaningful experience. You can read this review. It's a good overview on all the LSD studies that have been conducted. So, but like I told you, and what you're expecting is a presentation on microdosing, and microdosing is hyping. there was also a person who wrote this book, and a quote is shown from her. But there are a lot of books popping up, this one, and also this one. And he is the first true microdosing researcher. And an interesting thing is that back then, when these studies with LSD were done, and the first study on LSD and creativity was done, he was a student then, or student researcher. He continued his work. But what is microdosing? So we went into the literature, and we came up with this definition. We clustered all the findings. And what you find in definitions is that it's subperceptual, keep it in mind, and it has the intention to improve well-being and enhance cognition and emotional processes. So, that's what we know from anecdotal reports. People feel that they improve. People also use it as self-medication. I really want to show you this, and I really think understanding psychedelics is also going back in history. And I love the MAPS website, the Multidisciplinary Association for Psychedelic Studies. They have an excellent bibliography. And you can find old articles like this one, dating back from the 50s. And they already investigated low doses of LSD. And here in the graph, they show the doses and the extent to which people experience these feelings. Like mood, you see that it is increased, and heart rate too, pupil size. So basically, the research was already done back then, and now we're doing it again. We did a survey to know why people microdose. I know. You say, we all know why people microdose. It is on the internet, that is true. But we also need real scientific papers to show it. That you can say, well, scientific research has shown that people microdose to increase energy, enhance creativity, study, increase concentration, and la-di-da. But also to get rid of their physical or psychological symptoms. The survey was up for 2 months, I think, and we had a high respondence rate. I think almost 5,000 people all over the world filled it out. And here you see that this is microdosing for mental disorders, microdosing for physical disorders, and we asked 3 questions. Did you improve? And yeah, you can read, did your quality of life improve? And did the symptoms disappear? And we compared it to conventional treatment in the middle they received, and the macrodosing, the regular psychedelics. The bottom line of this is, here you see that people used it for ADHD. When you go on the internet, you see that people take it for their ADHD. And you see that it worked, and the symptoms disappeared. Their quality of life did not improve. Why this is the case, I don't know. We have to look into that. But also the interesting thing here is that people take it for depressive disorders and anxiety disorders, and it works, symptoms disappear, and quality of life improves. Let's now go to the reason why you're here and why I am here. Is we were interested to know whether a low dose really has objective effects on performance. So that's why we did our study. You also know when you're microdosing, you do not use one single dose, you do it repeatedly. But we do not really know what a microdose is. So that's why we first did a dose finding study to find out which dose does really do something. We wanted to know whether it improved mood, whether it improved creativity, empathy, and whether it outlasts the acute stage. So, like I said, we used the gold standard placebo-controlled acute study. We asked the general public, do you have experience with psychedelics? I always explain why we do that. You also have labs like the Basel lab in Switzerland. They use drug-naive people. We only use people who have some experience with psychedelics because back then, when we did our first study and we had to go to the ethics, we thought that we do not want to motivate people using these drugs. And we also want to know that people will have a good experience when they take it, because when you take MDMA, it can go wrong for some people. That's the same. You can also go wrong when you take an aspirin. But anyway, this was our message for the ethics committee. So we do that. And then we give LSD on 3 occasions in our study and placebo on another occasion. So 4 test days. And then they do questionnaires and tests. And then if we don't see effects, so if they had LSD, but the performance is equal to placebo, the drug doesn't have an effect. And if we see a change in performance, we know that it was caused by the drug. Because if you self-medicate and you feel improvement, you do not know whether it's your mind that improves you because you think that the drugs that will help, or whether it's the drug itself. That's why we do these placebo-controlled studies. Within subjects, so every subject comes for 4 test days. So we used 0, 5, 10, and 20 micrograms of LSD, 5 days washout in between, 24 participants. These are the demographics, and here the LSD is shown. Do not get me wrong, we did not inject it, but these syringes are shown because we had to take out the right amount of LSD, and then it was put in the mouth together with some alcohol so that everybody had the same amount, that they did not notice what they got. So this is how a test day looked like. It is a lot. Because when we have money and when we're able to do a study, we want to know as much as possible. But that's always a balancing act, because we do not want to ask too much from people, because they also need some time to experience the effects. Important here is we did questionnaires to see how their mood was. We took blood samples. We do not have the data on the BDNF yet. It's neuroplasticity, but we will see. I don't think that it was changed. And here were the computer tests, but I will explain them one-on-one. So the first thing is, it's very important when you do a study to have some safety measures to show that the drug is safe to give to people. In this case, it was blood pressure and heart rate. So here you see what it should be normally. This is elevated, high blood pressure, higher, and hypertension. This is what we found. So this is hours after administration. This is heart rate. The blue line is placebo, and the red line is 20 micrograms. The baseline here is we did not find effects on blood pressure. It was not statistically different from placebo. What we showed was that LSD statistically increased blood pressure. So if we looked at all the data, the maximum of blood pressure was in this range. High blood pressure, not hypertensive crisis. But the question here is it clinically relevant that it increases blood pressure? It's not in the danger zone, so safe. To know about the subjective effects, we gave these visual analog scales, and we also gave the profile of mood states to ask about their mood. This is what we found. In red is what I think is bad, and in green is what I think is good. So people felt that they were under the influence when they took all the doses of LSD, 5, 10, 20. Good drug effect, and it's debatable whether that is a green one or a red one. Bad drug effect went up with 10 and 20. I like the drug. Also debatable whether this is green or red. Because of the perspective of, if you look at it, does it have abuse potential? And people will say, if people like the drug, it can show drug dependence potential, but still. Feeling high, after 10 they felt it, happy. After 20 they were happy. Concentrated, it went down after 20. All subjective, it's what the participant experiences. I feel creative went up with 5 and 20, and I feel productive went up with 10 and went down with 20. So these are the results. We also use the altered states of consciousness, and all the scales went up. Why did I put it in red? Because it's not in line with the definition of subperceptual. People experience alterations. I will show you in another slide what they experienced. But this is very important, putting it into perspective. I started off with telling you what the effects are of full doses. So these are microdoses. I just picked 2 scales, the good drug effect and the bad drug effect, and this is a scale from 0 to 10 or 0 to 100 with microdosing. So you see that it's maximally, after 20 micrograms, a 4, not even. These are the data when you take a regular dose, 100 or 200 micrograms. So you see that there are perceptual effects or subjective effects, but are these relevant? They are there, but they're very small, micro. So again here, this is for the altered states of consciousness. You see that the effects are here, and for regular doses, really higher, very high. Cognitive functions. So we tested, this is, they call it a digit symbol substitution test, so you have to link the right symbol to the right digit. And it has a time component because you have to do it very quickly. This is a vigilance test, an attention test. A counter is running and you have to press a button as quickly as possible. And this is the alternate uses task. It tests creativity. So you're being shown 3 regular household items and you have to think out of the box what you can do more with that item. What did we show? Working memory, the first one, it went down. So if you have to do something that requires some thinking and has a time component, it will not be good. 5 minutes. If you have to do something like more vigilance task, your performance improves. So you don't have, and we call it attention lapses, you have less attention lapses. And that also links to, I showed you that people use microdoses to self-medicate for attention disorders. This might be the indication that, the objective indication that it might work in these people. This test, creativity test, did not show effects. So what we show is that people do not become more creative after a microdose of LSD. I'm going to quickly go over this one. This is the empathy test. So we tested whether people are able to recognize emotions, but also whether they feel more or whether they are more aroused by the emotion they see. Basically, no effects. No effects on cognitive empathy, no effects on emotional empathy, and also an interesting thing, we tested their empathic traits, whether they changed. We tested them at baseline and we tested them at the end of the study. So after 3 microdoses of LSD, it didn't change. This is what people said to us, what they experienced, their perceptual alterations. This is a door in the test room and it has prints on it. And some people saw that the text, it was moving. So it is important to know about this, because if we want to prescribe microdoses to people for ADHD, this might become an unwanted effect on the patient leaflet. Because if you are going to work and you see the thing on your computer screen moving, it might not be what you want. So we have to be clear on that. This is only for 18 participants. I still have to include other data, but we also asked them, what LSD amount did you think you got? On the day they received placebo, it was half of them guessed that it was blue placebo, and half of them thought it was 5 micrograms. And you see, so the blue one is the placebo guess. This is the actual dose they got. You see that the higher the dose gets, the more convinced or the more they are aware that they got something. Because here with 20, only a few people thought that they received placebo. So it is noticeable. And that's what you also hear from people who microdose. So the summary is that we found the best results with 20 micrograms, and some are in line with the higher doses, and some we are not in line because empathy did not change while it changes with a higher dose, and creativity that was not tested in a recent study. So, to the conclusion, I showed you the definition of microdosing, and we now know that when you are able to enhance performance, it is not with a subperceptual dose. And we also know that it's not only enhancement of cognitive functions, but we also showed that a higher cognitive function can be impaired. So you have to remember that it are small effects, not subperceptual. It's partially in line with higher doses, partially in line with previous microdosing LSD studies. Up to now, 2 studies have been published. One comes from the Chicago lab, and they showed that moods and altered states of consciousness was increased. There is also another study who showed that time perception changed. They did a between-subject study, and time perception went down. So I was also thinking, what could that mean? That's perhaps the feeling people get that they are more mindful when microdosing, that they're more in the moment. I do not know, I was just thinking about it. This is also very important. One dose seems to work, and even in healthy volunteers, so it might enhance or reduce symptoms in patients. And also something that we have to keep in mind, you can find statistically significant findings, but are they clinically relevant? That's something we have to find out. So what do I think we have to explore? Anecdotal evidence should be the starting point, and we should investigate that. If you would give me money, if somebody with a lot of money is here and wants to give it to me, I would like to start with microdosing people with ADHD, for example, and seeing whether it removes their symptoms. I also think that our studies are very relevant. We should see what it does in healthy volunteers, and then see whether it links to the symptoms, the psychiatric symptoms we find. We should look into the whole scala of psychedelics. Are the short-acting suited for one condition, long-acting for another condition? And we should also look into the persisting effects. We should do it repeated dosing. We're going to do that. And we should also not beware. We should keep our eyes open to see whether there are negative effects, because we just do not know. There has been a study with microdoses in rodents, and this is what they showed. Increased aggression, looking scruffy. However, anhedonia, yeah, hyperreactivity, sorry. But we do not know, and this is a very important question, whether animal research translates to humans. Where are we now? We should go through all these stages with phase 1 clinical trials being done in healthy volunteers to see whether it's safe, and then proceed to smaller groups in patients and larger patient groups. And this whole process takes 10 years. One last thing is, and I really think it's necessary to do this, and we should have discussions about this. This is what I read. Should we do it? Should we give it to healthy people? I think we should also think about this. So there are alternatives, and I think that we should first look into the options of making this available for people who really suffer or have lower well-being. These are my acknowledgements. Our first study was partially funded by the Beckley Foundation. I'm very grateful that we got the money, and these are our collaborators. And I would like to thank you. I would like to, and this is my hospital of the future with all the categories included. And I would like to draw your attention to this. And then that was it, folks. Thank you.
That was really great, Kim. I would like you to talk about cognitive flexibility versus cognitive rigidity.
Yes, so the question is about cognitive flexibility and cognitive rigidity. Like I said, we did not find effects on both measures, while we did when using ayahuasca or psilocybin in regular doses. So the question still remains whether we're going to investigate that in our repeated dosing study. Perhaps we will see it then.
Can you mention BDNF and neuroplasticity? Are you comfortable talking about that a little bit?
A study by Lai has shown that psychedelics increase neuroplasticity, so growth of neurons, and they showed it in cell cultures, or not in biological material, let's say. I know now, so we were very interested in this. That's why we took blood and try to determine BDNF. We know now that for the psilocybin study we conducted, a regular dose, we do not find increased neuroplasticity in humans. I also know that the lab in Basel, Switzerland, did not find this in humans after a regular dose of LSD. So I also do not think that we will find it after microdosing, but still then the question is not answered whether or not there is neuroplasticity, because we draw blood and we determine BDNF in blood, so it's an indirect measure. So I think that perhaps imaging will help there, but then still you're not able to show neuroplasticity. But anyway, my idea always is, people state, well, we have these results showing that it induces neuroplasticity. But is it really important? You also need this functional component. If you have a growth of neurons, what does it mean? People with autism spectrum disorder have also too many neurons, and does it help those people? No. So we should be able to really have the functional component. If it increases performance, that's all we need to know.
Great.
Thank you.
Thank you, Kim.